A lot of the burnout that we see in healthcare workers is not because of bad management. It's because of macro level or macroeconomic level factors that affect healthcare as an industry.
Hello, everyone, and welcome to the Bedsides and Boardroom podcast, where we speak about the intersection between business and medicine. Today, we've got a special guest, Justin Thomas. I would say soon to be doctor, but we'll get into that a bit later. Justin, welcome to the podcast.
Thanks very much for having me.
We go back quite a few years, but for the listeners, can you just tell us a bit about your career and how you got to this point?
I am a paramedic who studied in South Africa. Nathan and I met each other because we studied at the same university on the same degree. So I graduated with my bachelor degree in paramedicine in 2013, and then after that I left and went to work in rural South Africa. I worked there for about 2 years and then came through to work in Saudi Arabia, where I started working as a EMS duty supervisor for an airport healthcare service. From there, I was promoted to the chief paramedic position. After that, I left the project and worked in the company's head office as their health strategy manager.
Yes, yeah, you were just a few years above me when we were studying. Today, we're going to touch on leadership, and I've obviously started with your career because it just shows you started out, as we all do, yes, in medicine as a student, slowly progress, and we start our first clinical job and get more and more experience over time. So you've managed quite a few people in your life. What are some of the principles that you think are important for a manager to have?
So I think the leadership always starts with me. And what am I doing? How do I lead myself? I believe, and I learned this from the University of Johannesburg, from our lecturers, that the leader is before anything part of the team. After that, they are a team leader. If you as a leader are not willing to work within the team, then can you actually lead the team? So the first principle for me is leadership starts with being a team member. Why I learned that from UJ is through our PT sessions. Everything that we did at UJ, the lecturers were always part of the team. Nothing happened where we were expected to do something that our leadership was not doing with us. And so leadership for me is something that is always demonstrated. It's not something that is spoken about. The second principle is that leadership is demonstrated. You lead by example, not by telling anybody anything.
I think that's such an important point, just to say that a leader is part of the team, and whatever rules apply to that team should also apply to the leader. So anytime that there's extra work that needs to get done, the manager should start doing that. It shouldn't be always delegated out.
Yeah, without question. I think that the bit of a misnomer within healthcare is that leadership within that team, or that the admin side of it, the management side of it, has a direct effect on the clinical side of it. When you sit and you study healthcare as a system, what you find is that as a system, it is complex. Complex systems do not always work where authority is centralized. You have two different hierarchies. You have the administrative side that does all of the admin work, that does the part of making sure that there's stock, making sure that, the leave is correct, that the rostering happens, that the cleaning takes place. And then you have the people who actually do the work. the clinical work, who work with patients, who treat them, who do all of that. Those two entities rarely ever mix. Normally what happens is that your staff members, your nurses, your doctors, your paramedics almost never know what is going on in the admin side of the organization.
Absolutely. And I think that is always the tension between the admin side of a healthcare organization, which has to focus on budgets, has to focus on supply chain problem, logistics, all of these things that as clinicians we don't always see. And we get very frustrated when we go into the storeroom and there's not the drugs that we need, there's not the medications that we need, but we actually don't see that other side, the admin side of the business, the challenges that they have.
Yeah.
Um,
I think that when you begin to look at that and you sort of understand that there is this tension, a lot of the burnout that we see in healthcare workers is not because of bad management. It's because of macro level or macroeconomic level factors that affect healthcare as an industry. For example, the biggest factor that affects healthcare currently is that there is predicted to be a 15 million person shortage in healthcare workers by 2030. So according to the World Bank, we're supposed to have around 80 million healthcare workers around the world. Currently, they are predicting that we will only get to 65 million. So what does that mean for a healthcare organization? It means that the pool of people that I am employing out of is already limited. So it's not that we're not sitting and trying to find people to come and work. It's that the people don't exist.
and a healthcare organization needs to have both. In
Yeah.
order to provide a service for our patients, we need to have both arms of a medical organization working together. Now, we mentioned this before that you are uh, currently doing your PhD. You've obviously got a master's degree. Um, Tell us a bit about your research that you're doing and how it relates to leadership.
Sure. So my work focuses specifically on how context influences decision making at the point of care. So I want to understand when a clinician is working with their patient to discuss and decide upon the care that that patient will receive, what contextual factors do they take into consideration when they are doing that? And how does it actually influence that? And what the research has basically shown is ambulance services are number one complex systems, so that decentralized approach to leadership needs to be in place, where the people in the front line are able to make decisions for themselves and deal with problems that are happening at the scene, because the people who are not there may not be able to make those choices. Very importantly, they may not be able to regulate those choices. Why can they not regulate it? Because most of the time, the factors that are affecting decision making are unpredictable or not controllable.
Absolutely. And I think it goes down to all of those other aspects of decision making that we need to consider when we're making a decision for a patient. What are some of those factors that you've seen influence the way that clinicians make decisions?
So, clinicians generally, when they are working in systems, they operate by two sets of rules. You have what I call formally applied rules. These are things like laws, policies, procedures, guidelines that act upon the system to try and control behavior within the system. Then you have something called emergent informal rules. And what these are sort of practical guides that people use to overcome problems that they encounter whilst working within their organization. It becomes a rule when that team learns that um, uh, their practical plan worked well, and then they share that plan with other team members. And so it begins to spread to different people who begin doing the same thing. But that rule is not a formal rule. It's not normally part of a policy or a procedure or a law. It's something that guides practice at the point of care, but is not integrated always into the formal procedures. So something for me that I have found that affects this is something that I call policy, procedural, practice, congruency. Those three things must align. What is in the policy and the procedure must be in practice, and what is being practiced must be reflected in policy and procedure. That has implications for a company who is designing those rules. It means that your policy and your procedure is not a fixed document. As a team leader, you are working with the people in the front line to understand their practice, to know what happens on the ground. So you can take those things and bring it back. What does that look like? It means that we have to ask two questions. The first question is what we have written in our policies and procedures required for practice? The second one is what is required for practice being put into those policy and procedures? And then if there is a difference, ask why.
That's the difference between the way an organization uh, is policies written and how it actually functions.
Yes.
And so many times we have people within the organization that circumvent policy, but just because those people are the best at doing that and they've done it before, and that role just kind of gets assigned to them, and there's this misalignment with policy and what is actually being happening on the ground. Now, that kind of disalignment can lead to a lot of frustration. So we have to constantly be motivating our staff members, trying to get them to not only follow the policy, but to treat patients well. How do you go about motivating your staff members, maybe when it's not so easy, when the organization does have these flaws?
So, what I learned during my master's degree is that healthcare workers have a very specific characteristic trait or set of characteristics. They are motivated by helping people. So that is what they want to do, that is what they like doing. Put them in spaces where that is what they do. The second thing is that most healthcare workers are generally high achievers. And that means that they generally have an intrinsic motivation to succeed. So in that space, they will work by themselves because they have personal goals, they understand what they need to do, and they generally are very goal oriented because healthcare is a goal oriented discipline. You always have specific goals that you want to do for that patient, milestones, whatever. And when you achieve them, you modify, you move on to the next one. So the way you keep these kinds of people motivated is by not micromanaging them because they don't need to be micromanaged. They do their work by themselves with very little need for anybody to come in and tell them, do X, Y, and Z. But this is also something that's very important for a lot of leaders and managers to understand, is that the clinician is not going to do something that's going to compromise the patient's care. So they are
Yeah.
far more likely going to follow the instruction of their clinical supervisor over the instruction of their administrative supervisor. And I think that a lot of the challenge that you have with demotivated staff members is because that hierarchy, that difference is not respected. The administrative management think that they can impose onto the clinical staff things arbitrarily. So things that just randomly, oh, we're going to implement this new procedure because it's good for business.
Yeah, because in medicine we have this overarching responsibility to patients that are not customers. So
Yeah.
we have to ensure that our practice is evidence-based, it's pragmatic, it's in line with best practice, ethical. And I think that's important to realize in healthcare that we don't have, say, in other industries
Mm.
where, if you don't get your coffee on time or it's not as hot, it doesn't affect you in the way that if you got the wrong procedure. There's a much more real responsibility that healthcare organizations have. Now, you've touched a little bit on some of the traits of healthcare providers, maybe why they are sort of could be a little bit easier to manage. Maybe they might be a little bit more difficult to manage. If you say someone is headstrong, goal orientated, their goals might not always align with your organization's goals. So that might be a difficult thing to manage. But what are some of the other traits that you found are, first of all, uh, easy to manage within healthcare? And what are the ones where you found are quite difficult to manage?
Sure. So people are not cattle. It's that simple. They oftentimes will resist direct management. And that is also not the goal of the manager. The goal of the manager is not to manage the people. The goal of the manager is to manage the system that the people operate in. So if you as a leader are working to control your staff members, what they are going to learn from that is I cannot make decisions. I must do what my leader says. So they will stop making decisions. And that leads to this phenomenon that we see where a lot of managers experience burnout, especially new young managers who have transitioned because they don't always understand this dynamic. So if you want to micromanage, what's going to end up happening is you create a lot of extra work for yourself, and that leads you to burnout. The goal of leadership, the goal of good management practice is to create functional team members that can work independently of you. A lot of times you find staff members that resist delegation because they don't want to take responsibility. And that does happen. We had that. I personally experienced that in a service that I led at the airport, where when I got there, because of the way um, let's call it discipline was handled, a lot of the time the staff members felt that they were blamed for things. There was a blame culture where if anything went wrong, it was the frontline staff members who were the problem. And so what they ended up doing is they refused to take any form of responsibility for anything. And the
Mm,
result of that was that everything happened under the direction of the doctor. They would not do anything unless the doctor had said.
mm.
And in an
And that's extremely
ambulance,
inefficient, extremely
extremely,
inefficient. Yeah.
extremely.
Mm,
What ended up happening is that an ambulance call would end up lasting an hour and a half, 2 hours, because they had to wait at the terminal clinic and all of these things, because every patient would have to be transported. And then from there, the doctor also didn't want to take responsibility to manage the patient because of this exact problem. So they would refer. So you had this unnecessary referral of a person to a hospital who could have been managed easily because all they wanted, for example, was a bandage on a finger
mm,
or their blood pressure checked or something like that. And so when we came in, we actually had to work on that, which was difficult. There was a lot of training that needed to take place. We had to implement standards, that this is the standard, this is what we expect of you. Train the staff members to give them the skills to do that standard, but then also work with them to understand why they feel the way that they felt. And that was a very useful process, actually, because what we began to understand is that a lot of the reasons why they were making their choices and doing what they were doing had nothing to do with them. It was because of system-wide things that they felt pressured into doing. So, for example, if they were at a scene and there was a security personnel who was at the scene telling them to move the patient. They didn't feel that they had the right to tell the security personnel we're not going to. But that information as a team leader gave me the ability to then go to my management and say to them, these are the issues that we are receiving. Is there something we can do? You sit on these clusters, you sit on these committees. Can you bring our problems forward? And that's exactly what ended up happening. So what we were able to do is we were able to put directives on the ambulance. So going into it and understanding what is the team's issues, what is affecting the mechanisms of behavior, and then working to fix those at a system level really helps build motivation for your staff members, because they realize, oh, actually, okay, this person's going to fight for me, so I can do my work and I can do it properly. I'm not going to be the person who gets blamed for everything, so I'm not scared anymore.
I always talk about the shape of a triangle of an organization,
Mm-hmm.
and to if you have a shallow triangle, you have a lot of people at the bottom that are kind of doing the work, and then you have
Mm-hmm.
a very few people making decisions in that organization, and that is extremely inefficient because people do not feel empowered. All decisions are going through one kind of bottleneck. Whereas
Yes.
if you have a more shallow um, organization, you have decisions being made at the appropriate level, and then those are eventually filtered up, and bigger decisions are made higher up, and smaller decisions are made lower down. And I think that is much more efficient way of running any organization is to empower those levels. Now, this goes a lot into the organizational culture. And how do you think is a good way of improving culture?
I think that the first thing to recognize is that organizational change and cultural change is very difficult. So when you look at the anatomy of a system, the culture is the deepest part of that system, and it's the most difficult part to change. It takes the longest period of time. A lot of what change managers try and do is the quick wins that are at the surface level because we can quickly implement a procedure to fix X, Y, and Z. Not understanding that actually the reason X, Y, and Z happens is because there's a communication block between this person and that person at much deeper levels. And that if you fix that one stupid little block over there, then all of the dovetail goes away. So that leads to a couple of things that I like to do. The first part of it is training, always. You have to train people in the new culture that you want. The second part is you have to actually have a standard that you are looking to achieve. So that standard needs to be achievable, and the people need to believe that they can achieve that standard. Otherwise, they give up beforehand. So normally, organizational change and especially cultural change happens in steps, in increments. And what you find is that you have short goals to get you to the next goal so that the team believes this is achievable. And the win motivates them to continue, because that in healthcare is a big gripe amongst a lot of clinicians, is clinical governance and the way clinical governance is implemented. Clinical governance is not about beating people over the head because they didn't follow a flow diagram. Clinical governance is about ensuring that the system promotes your outcome that you're looking for. So if you have a standard of care that you want, before you ever look at the staff member, your first job is to look, did they have the tools that they needed to get? If they don't have the tools that they need to get there, do not even bother with the staff member, because it doesn't matter who would have been there, the outcome would have been the same. If the patient required intubation and there was no laryngoscope, no one was going to be able to implement or to intubate.
For those in the from the business side, intubation is where you put a tube down through the trachea and you can
Yes.
breathe for the patient. So this is sometimes what people refer to as being on life support.
So let me use a more everyday example. Um, uh, if I want a person to do online training and they don't have a computer, they can't do the online training. It's a
Mm,
physical barrier that prevents them from doing the task. So my job is to sit and look at, we've created the standard. How do our systems support our staff members in achieving that standard? Very, 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 very commonly,
mm.
if you talk to the staff members, they will tell you where the problem in the system is that prevents them from getting there. So the third thing that you can look at then is integrating people into the process. Don't leave them out of it. Consult with them. Find out what's happening with them. And then take that information and see how does it apply to our current systems.
And I think that's a nice way to frame it in terms of being a manager or being a leader.
Mm.
And what is it to manage people, as in, say, boss them around or tell them what to do? And what is it to be a leader?
So for me, the difference is that managers are there to manage the system, leaders lead people. To be a leader, you have to be part of the people, one in the team, demonstrate it. So again, leadership is about leading by example. I expect you to do the standard because I am compliant. I can. If you need help achieving that standard, come to me. I will show you how.
And there's certain challenges that people have outside of their work. People have lives,
Yeah,
family issues. So a relative might die. They might have a wedding, and they might have something that they're saving for, or something like that. So, going back to the point of it's just not being cattle. We can't treat all members of our team exactly the same.
yeah.
It's about fairness, but it's also about um,
Compassion
justice,
and
providing,
empathy.
yeah,
Yeah.
and providing people with the opportunity to flourish within their social constraints or within their work constraints. So that's how we
That
get the best out of people rather than
100%.
trying to just get them to do something all the time.
Yeah. I think that compassion and empathy is often overlooked in leadership discussions and especially in ambulance services specifically. What I have found is that teams are far more willing to work with you through difficult situations if they believe you are actually compassionate about them and you do want their well-being. They are far more willing to accept compromise, to go the extra mile when they have received that level of compassion from you.
And I'm always interested about how we use lessons from other industries within ours. So I always like to look at another industry and say, what can we learn from there that we can implement in our industry? So going the opposite way, what would you say that what would you say that are examples of things that we do right in the emergency setting that other fields can learn from?
I think that we do teamwork very well. If you are part of a good quality team, which most people who work in emergency departments or ambulance services are, generally because you are always on the same shift cycle and your shift members doesn't normally change. So you learn that person, you understand how that person functions, how they work, what your role in the team is, what's expected of you, all of that kind of thing. So I think the teamwork is the one thing that we do very well. And then the other thing, obviously, is crisis management because we
Yeah.
often meet people in crises. So understanding how to work under pressure, understanding how to work with limited resources, understanding how to work with the unknown. I think that we manage uncertainty far better than the vast majority of other people. And that's just because we never know what's going to be there. So you find that that people in emergency medicine, they tend to be comfortable with the unknowns a lot more than other people are.
mm,
And it doesn't stress them out as much. If we don't know, that's fine. We'll deal with what
mm,
we know. Let's solve these things. And when we know that, we will cross that bridge when we get there.
mm. No, I think that's such a great point because, I mean, even just we both know what's happening around
Mm,
geopolitically around our region, and I've just kind of you know thought let's deal with one thing at a time. We can control this. This we cannot control, so let's just leave that. Whereas my wife, on the other hand, I sit down and I chat to her, and it's just like, what are we going to do? And she kind
mm,
of almost spirals into thinking of all the things that need to be done, rather than this is the issue that we've got now. Let's make a decision and let's move on to the next pressing issue, and then we
yes,
will make a decision there, and then control what we can, and push all the other stuff is that we can't control out of our minds. And I think that's something that we tend to do well
yes,
from the emergency
yeah.
medicine side.
I agree with you. I think it also touches on communication. I think that emergency medicine practitioners are good at communicating generally. We're good at giving direct instructions. We're good at giving clear, easy to understand, practical advice um, uh, that can easily be followed. But we also understand when we need to be in the trenches and when we need to pull back because crisis management teaches us that. So
Mm,
sometimes you have to be involved to do something, but then pull out to see the bigger picture. So for me, that is a sign of poor leadership or poor management. If you have a manager that is always involved in fixing the crisis, or always there, always the one doing stuff, it's a sign that maybe the team dynamic that is there might not be optimal. And that maybe some teamwork and leadership coaching or workshops need to happen there. So, one of the things that I like to think about when I think about teams is everybody in the team is equal, but not everybody has the same responsibility. So, understanding when to let your team lead and do their job versus when not to is a core skill. And it's something that we learn very, very clearly from clinical work.
absolutely. That is a great way to round out the episode. Thank you, Justin, for your time and your incredible insights. I'm looking forward to your research from your PhD.
Thank you.
When that is published, please let us know. But thank you
Sure.
so much for your time. It's been a great episode.
Thank you very much for having me. I enjoyed it as well. Thank you.